Okay, hi, Dr. Dave Webster, and this is my next in the video series. I'm asking you to consider whether we should be calling Dr. Eric Hoskins, or Minister of Health, or Minister of Disease, based on some examples of PET. And this is about lung cancer victims in Ontario, and I've done this as a two-part video to maximize the benefit, and so that each video is not too long. But as you watch these two sets of videos, what I want you to understand is that up to 90% of OHIP-funded lung scans, as established by Cancer Care Ontario and their McMaster evidence-based medicine colleagues, are for lung nodules and lung cancer. These indications are in fact the exact opposite of the entire world expert body of opinion. And as you might have already guessed, this is probably not what's best for our patients. So this is Dr. Hoskins' agenda for lung cancer patients in Ontario. Before we get into that, I just want to give you a bit of information so that you'll have a better understanding why PET has been, FDG PET in particular, has been the acceptable standard for lung cancer nodules and so on for at least 25 years, and in places like Chile and Argentina way back then. So why is that? This will help, hopefully you understand that better. But as I've said before, if you watch my earlier videos about PET, all cells can use glucose or sugar for fuel. So what we do is we use less than a billionth of a gram of a radioactive form of sugar called fluorodeoxy, meaning an oxygen removed, glucose, or FDG. And you've seen that in other videos. The key point on what's made this so useful, however, is that it turns out cancer cells can only use glucose as a fuel, and typically they use it very inefficiently. So that if we inject radioactive glucose into a patient and the master's cancer there, it tends to take up a lot more of this radioactive sugar compared to the normal cells. In addition, it turns out with PET scanning we can actually quantitate how much sugar is taken up, or get some number or value for that, and then we can compare the amount in the average normal cells to what's in the mass and get some better information, as you will see. And there's many ways of doing this, but the most common one is called the standardized uptake value, or the SUV max. And so we take the maximum amount of glucose in the tumor or mass we're looking at versus normal tissue. So let's expand on that. An SUV max value of 1 simply means that the glucose uptake in the mass we're looking at is equal to that of normal cells. Doesn't mean it's normal, but it's equal. That's what the value means. Now, if we have an SUV max of 2.5, that simply means that there's 2.5 times as much, glucose uptake compared to the normal background glucose uptake in the normal cells. Now it turns out if you have a lung nodule, that if a lung nodule has a little mass, has an SUV max of 2.5 or greater, it now has over a 90% chance of being cancer. Now remember, this is just sugar, so it doesn't mean it's cancer. The only way of establishing that, as we'll see, is with a biopsy. There's many other things that can have sugar uptake, and it turns out many useful other uses for PET that were not allowed in Ontario, as you will see in other videos. So therefore, the only way to make the difference, as I've said, or find out what the cause is to get a biopsy to determine the cause of the mass, and then we'll have lots more to say about the role of FDG PET in getting a biopsy. So I'm going to use this case frequently here, but this is in the lung nodule, an 11 millimeter right apical lung nodule, right lung, left lung, and it has a low SUV max of less than 2.5. This patient was ultimately able to get an FDG PET scan, and in fact the SUV max value was only 0.7. You can see it right there. It's less than the background normal tissue you're seeing here. You see, this is the vertebrae, for example, here. So as I've said, less than a 5% chance of being a cancer. So this patient does not need a biopsy. We now confirm this patient with just serial scans, PET scans, and if getting significantly bigger or taking up more sugar, then it doesn't mean it's cancer, but no, you need to get the biopsy, and that would be reasonable. But in addition, it isn't just guiding you about the biopsy. If this ultimately does turn out to be a cancer, the fact that it has such low sugar uptake tells us this typically will not be an aggressive cancer, and even though there's been a delay in making the diagnosis, the patient should do just fine. Now, on the other hand, let's look at it with a high SUV max, and here we now see about a 5 centimeter mass in the left lung. This is the left and right side of the patient. patient. They have the scan, and it has an SUV max of 12.7. So 12.7 times background. You can see the very faint background here, how this really shines out, right? Now this mass has up to a 90 to 95% chance of being lung cancer. Clearly you're going to need a biopsy to determine if this is true or not. But in addition, as I've said, we get more information. The fact that this has a high SUV max tells us, on the other hand, that this is a very aggressive cancer with a poor prognosis, no matter what this patient's stage is. So, for example, if this patient actually turns out to have operable cancer, there's been no spread and so on, regardless, this is a poor prognosis. So the physicians immediately know they need to use more aggressive therapy in this particular patient to improve their chances of survival. So this is a standard chest X-ray. Somebody's had it for whatever, physical, whatever, and this is what this is the right side, the left side of the patient, your trachea, air tube, your heart, and so on, the diaphragm. But this little 3 centimeter nodule, now just based on that chest X-ray, it has maybe a 30% chance of being cancer. And in the entire rest of the world, and for more than 25 years, the standard has been to do an FDG PET scan next. And if it's a low SUV max, as we said, conservative clinical follow-up, serial scans, and you can decide whether or not you need a biopsy after a couple of times. If it's nothing's changing, then you can just ignore it. And in fact, for I think more than a decade now, U.S. health insurance companies won't even pay for a diagnostic CT scan because they know that the best way to decide what's the next step in this pathway, and of course cheapest of the insurance companies, is to do the FDG PET scan. And so if we see it's a high SUV max, as we said, we biopsy it. Now, in Ontario, the Cancer Care Ontario compulsory guidelines we as physicians must follow is you have to do the biopsy first before you get the PET scan. And in the second part of the video, you can see the profound problems that creates for patients. And remember, this is the exact opposite of the entire world expert body of opinion, but standard of care in Ontario. So what is the implications, of course, for the patient? This creates an absolutely unnecessary delay in diagnosis, and if it ultimately turns out to be lung cancer, starting appropriate therapy. And I see this on a regular basis. That delay can be fatal. They get an absolutely unnecessary overexposure to CT radiation, which has been almost useless, as we see repeatedly on the studies I'm showing you. And they may have, as you'll see in the next part 2 of the video, unnecessary high-risk biopsy procedures with all sorts of complications that the PET would show aren't necessary. And never forget the absolutely unnecessary exponential increase in the anxiety and stress levels for their patients and families who already obviously have really high levels of stress to begin with. So let's go back to that patient again. This is the 64-year-old smoker, history of breast cancer. She's having back pain. The physician wants to know, is it cancer spread to her back, or is it just arthritis or something? So we now have done what's called a bone scan and fused it with a CT scan. So a bone scan is another nuclear medicine study, and in this case, these red spots here, this is the CT, as you can see. The red spots aren't the glucose being taken up, but this is, think of it as a radioactive form of phosphate. So this case, what we're looking at is if there's more bone being made, we see more radioactivity here, and that's simply what it's telling us. And by combining it with the CT, this is a very crude CT, but nevertheless, we can say, look, this is degenerative disc disease. This is not cancer or arthritis or something like that. So the patient gets that. Now, but in addition, because I do have the lung windows, I looked at them and I did find this 11 millimeter apical nodule. So what do we do then? Now, if this happened to have been in Quebec and it turned out, say for example, that an SUV max of 4 times background, you definitely want tissue, a biopsy, and undergo that procedure. If it turned out to be cancer, within 6 to 8 weeks, that patient could have been on the appropriate therapy. In Ontario, I see this all the time. This could take easily 1 to 2 years with repeat CTs and with gross overexposure to these all but useless CT scans. And by the way, the patient can only be followed by these CT scans. And remember, you still have to have the biopsy before you can even have the PET scan. And again, we'll see what that means in a second video. So this patient said to me, and also to our thoracic surgeon, my life is on hold. I simply cannot sleep at night. She was just consumed with anxiety. We do know, as you see, that we were eventually able to get a PET scan in a tricky sort of a way, but we did. It has an SUV max of 0.7, less than 5% chance. Her personal stress and anxiety levels fall exponentially, and I know this patient personally, and I can tell you that was clearly the case, and wouldn't it be for you? This is the essence of what we mean by personalized molecular medicine imaging. Now the vast majority of patients, with rare exceptions, as the patient was, cannot have a PET at this stage, and most would agree. However, they still feel the same way. Their lives are on hold. They cannot sleep. They're consumed with, do I have cancer or not? Now, but what if, ultimately, after this delay, it turns out that it's cancer? Now, the patient will now realize that they've actually had cancer from day one, and it's been missed for 2 years before they actually start the proper treatment. So, anybody want to guess what that means for this patient's chances of survival because they have the misfortune of living in Patients First Ontario? And now imagine their levels of stress, anxiety, and fear. And I assure you that this is deliberate, and everyone from the government and their experts are all very pleased with this. We're going to continue to ask them what they're so pleased about, but in fact they are, and I will show you the evidence that that is the case in subsequent videos. Now, the point is how did the government's medical experts come up with an indication that is, in fact, the exact opposite of the entire world expert body of opinion? So how they did it was, as I've said in another video, they simply took a mere medical poster on a couple of pieces of Bristol board. This is not in any way, shape, or form scientifically valid at that point as a poster presentation. But this poster didn't favor PET in lung cancer, and this single poster was used to stop the introduction of PET in Ontario cold tracks. In fact, they would use this poster to take the recommendation of 40,000 patients who would benefit in the late 90s to PET scans by this independent committee that looked at these uses, down to 0 patients would benefit because of this poster. Then and again, this poster didn't end there. This poster would then be elevated to a level A high quality evidence paper. We have A, B, C, and D. The high quality evidence paper because it didn't favor PET, but what they did was they then took papers that clearly did favor PET in lung cancer and they demoted them to unsatisfactory levels of evidence, and that's how we've come up with this indication that is exact opposite of the entire world expert body of opinion. In addition, just as a note here, when they did run the lung cancer PET experiment on patients, what they didn't do was tell them, as they were required to do by ethical experiment, that this already was the world standard of investigation management of lung cancer even then. So, end of part 1 of whether Dr. Hoskins should be Minister of Health or Minister of Disease. We're going to go to part 2 in a moment, but I want you to keep in mind that I'm being threatened by Cancer Care Ontario and the College of Physicians and Surgeons of Ontario for making these facts available to physicians and patients. And in fact, I just am finishing now, as I gave you this, just before I did this video, I sent out my final response to my being investigated right as I make this video. So part 2 will be the unnecessary assault on lung cancer patients with a large biopsy needle. Clearly that biopsy needle has to be put in the chest sometimes, and you'll see how PET can help us guide that. Thanks, and we've got to make that change.